In 2006, I stood before a room full of NHS colleagues and asked one simple question. When a person feels unwell, how do they know whether to stay at home, call a nurse, triage, visit a chemist, or go to the hospital? The room went quiet. Not because the answer was complicated, because there was no answer. There were 7 different systems, 7 different phone numbers, 7 different doors, and no way for a patient to know which one to use. 7 fire alarms. And none of them told patients or me which fire to run from. I had worked in pediatric intensive care, examining every critically ill child as a senior doctor and training junior doctors to manage critically ill children as a family physician. I watched children die not because medicine failed them, but because they arrived too late or went to the wrong place or sat in a waiting room breathing the same air as someone carrying an infection they should never have been exposed to. Family physicians were also not referring patients, but often request tests, investigations, and so delay occurs. This is not because the doctor in the hospital expects the family physician to refer patients after diagnosing. This is because the family physician gets paid by the local laboratory for referring a patient. Sad, but this is true. That photograph, that crowded polyclinic waiting room, I called it what it was, a bug-breeding chamber. People with minor ailments sitting next to people with serious infections, waiting 2 hours to see a doctor who would spend 8 minutes telling them what they could have worked out at home in 5. In 2010, the Times reported that 51.4 million GP appointments per year in the UK were for minor ailments. 51 million appointments for coughs, colds, headaches, and indigestion, conditions that could be safely managed without a doctor at all. The NHS was spending billions treating worried people who were not actually ill, while genuinely ill people waited weeks to be seen. I had already seen the other side of this. I've been predicting the antibiotic crisis since 1989. I knew what happened when resistant bacteria took hold in a waiting room. I knew what MRSA could do in a hospital ward. And I watched for decades as nobody connected these two facts together. The insight behind Maya, behind everything I have built, came from a question that sounds almost too simple. What if a patient could identify their own symptoms before they saw a doctor? Not diagnose themselves. Do not replace the doctor. Simply know whether their symptoms were an emergency, a concern, a minor problem, or nothing at all. 40 years of clinical observation had taught me one thing about diagnosis that medical schools rarely state plainly. 3 symptoms together tell you far more than 1 or 2 symptoms separately. A child with a runny nose is not alarming. A child with a runny nose, ear pain, and high fever is a completely different picture. The combination is the signal, so I built a system based on that principle. I called it Maya, medical advice you access. The patient identifies 3 symptoms. The system matches them to a color code. The color code tells them what to do next. Red, speak or consult a doctor now. Green, a nurse can help. Blue, probably infection, so isolate at home and speak to a doctor. If yellow, self-care, you will be fine. 4 colors, every symptom combination in the human body mapped to one of them. No medical training required, no literacy required, no internet required. I did not theorize about this, I tested it. In a 2-week pilot study with 2 doctors and 700 patients, we asked one question after every consultation: did Maya correctly identify what the patient needed? More than 500 of the 700 patients were correctly triaged by Maya, and the clinical examination data was equally striking. Only 16% of patients who saw a doctor actually required a physical examination. 84% could have been directed elsewhere to a chemist, a nurse, an administrator, or told to stay at home. 3 in 4 patients sitting in that GP surgery did not need to be there in the way they came. And the longer they sat there, the more they were exposed to whatever the person next to them was carrying. I presented these findings, I showed the data, I published in Anesthesia, I wrote to health ministers, I built the physical display unit, I installed it in GP surgeries, I watched patients use it, I watched them understand it immediately, because color is a language everyone speaks. This is not unusual in medicine. Barry Marshall drank a petri dish of Helicobacter pylori to prove it caused stomach ulcers. The gastroenterology establishment dismissed him for years. He eventually received the Nobel Prize. I am not comparing myself to Marshall. I am saying that when a simple, inexpensive, patient-centered tool threatens a system built around complexity, expense, and doctor dependency, the system pushes back, not out of malice, out of inertia. But 2025 is not 2006. The crisis I warned about for 30 years has arrived. Antimicrobial resistance now kills more than 1 million people directly every year. India's hospitals report carbapenem resistance in nearly 60% of Klebsiella isolates. We have fewer effective antibiotics in development than at any point since penicillin was discovered. The post-antibiotic era is not coming. For millions of people, it is already here. And artificial intelligence has finally given me the infrastructure to do what a wall-mounted display unit and a set of color-coded cards could only do in one room at a time. Dr. Meyer GPT takes the same color-coded symptom recognition system I developed between 1989 and 2003 and delivers it to any person with a smartphone or any village with a PREMA Kiosk. In any language, without a doctor, without a blood test, without a waiting room. I am a retired physician living on a pension in India. I have no institution behind me, no research grant, no department. What I have is 50 years of clinical observation, a system I know works, and the knowledge that if it is not deployed before 2030, the window will have closed. I built Maya because a patient should never have to stand in front of 7 fire alarms and not know which one to pull. I built Dr. Maya AI because the same patient should never have to travel 2 hours to a clinic to be told they could have stayed at home. And I built the PREMA Kiosk because the patient in a Bihar village or a Karachi slum deserves the same answer as the patient in an NHS surgery, and they deserve it in a room with no shared offices, no waiting, and no risk of leaving with something worse than what they arrived with. Stop, save, survive.